Right, if you're happy, shall we get going? Um, I'm Samira Ahmed, and I'm very pleased to be chairing this news conference where the Independent SAGE will formally present their report, COVID-19, What are the Options for the UK? Recommendations for government based on an open and transparent examination of the scientific evidence. Coronavirus has been a particularly difficult crisis for news media to cover, with the virus challenging our way of life, killing, well, tens of thousands of people across the UK, 40,000 it's thought, disproportionately impacting on BME communities and causing the worst drop in economic output for over 300 years. The Independent SAGE was brought together after concerns that the activities of the government SAGE had been kept secret, with their scientific approach and strategy excluded from scrutiny from the public, Parliament, and the wider scientific community. We're going to hear first from Sir David King, who's a former Chief Scientific Advisor who'll be making opening remarks. Can I just please remind media to mute themselves until they're given a chance to ask their questions. One question per media outlet, please, until we've got through all the questions. So I'm delighted to be able to call on Sir David King to make his opening remarks.
Well, I think I'm going to start by saying the function of the Independent SAGE Committee is to provide additional constructive evidence into government, but also into the public domain to manage our way out of this crisis. And it is this particular report has been produced over the last week by a group of top scientists, top international scientists. And I have to tell you, I have never seen such a comprehensive report produced so quickly in my 50 years in the scientific arena. So it's been a tremendous effort by all of them. And I first of all want to thank them all. They've all done this, of course, without any pay. None of us have received anything. Now, just to go through what I consider to be the main points. First of all, there was an apparent decision to stop testing and allow the epidemic to spread and build herd immunity. And it was criticized as the government told resumption of contact tracing and community quarantining was critical to stop further waves of the epidemic. So what we are not happy with is that decision in the past allowing the epidemic to spread. The report also criticizes inaccurate, incomplete, and selective data presented by government officials and calls for the Office of Statistics Regulation to publish further assessments of the statistics presented to date. We're afraid there has not been a reliable record from government. Top-down centralized approach from number 10, which has characterized the entire outbreak, must be replaced by equipping existing local public health teams to track and trace every case. GPs and primary care are central to the success of virus control and should not be bypassed. Government is urged to adopt dynamic, forward-looking modeling. At the moment, the modeling used, the R-factor modeling, is backward-looking, maybe 3 to 4 weeks out of date, and is used to monitor the lockdown decisions. This can be replaced by a forward-looking modeling approach, which allows us to foresee how R will develop with given strategies. Latest messaging from the government is sharply criticized for ignoring advice from behavioral scientists. Stay alert and control the virus must be replaced with advice closely linked to action. Comprehensive advice includes stopping COVID-19 patients from being sent back to care homes and addressing disproportionate impact on older people and on BME communities. The government must promote 14 days quarantine, not 7 days, and isolation facilities for vulnerable people must be provided. Finally, we think it is foolish to bank on the emergence of a vaccine soon. Obviously, we all hope that a vaccine will emerge, but the government must prepare for recurrent local outbreaks for at least a year by investing now in local healthcare systems. Thank you.
Thank you very much, Sir David. So I'm going to call questions from the media. I've got a list and I will work through everyone, and then other people who haven't had a chance to ask a question will also have an opportunity. So the first question I've got is Thomas Moore, science correspondent of Sky News. Don't forget to unmute.
Hi, thanks very much indeed. Yeah, no, I want to pick up on your concern about the statistics that are being given daily. What is it about them that you feel may breach the statistics code? What more would you like to be provided to ensure that we have a robust tally of what's going on in the epidemic now?
Who wants to take that one? Sir David.
Let me just comment very briefly. The Office of National Statistics puts out data which is fully validated data. We can rely on that data as the best available. The data, as we all know, doesn't match up to the data that is produced by government on their daily basis. So there are mechanisms for doing this, and it may well be that the best process is to take a weekly analysis going forward in time.
Thank you. The next question I have is David Shukman, BBC News. Oh, sorry. Before we speak, Alison Pollock wanted to respond as well. Please go ahead.
Yes, and just to say, these concerns are parallels. The chair of the National Statistics Authority has written to Matt Hancock about the testing targets which are being presented for much greater clarity about the purpose of testing the patients they relate to and what the purpose is. And it's really important. I think, you know, one of the recommendations is that there should be an official statistician that's actually presenting the data, because it's essential that the public have trust in the accuracy and the reliability and the quality of the data and what's being communicated. So that's why we put a very special recommendation into our number 3 of our recommendations is around data and making sure that government ministers and officials do not breach the code that's in place, the code of practice.
Thank you. I'll take the next question now. David Shukman, BBC News.
Hi, thank you very much indeed. You mentioned that quarantine should be extended from 7 to 14 days. Just wondering what the science was that led to that recommendation. Thanks.
Deenan.
Sorry, who's taking that one? Who'd like to, oh, is that Sir David again?
Deenan.
Sorry, I can't.
Yes, hello.
Sorry, do you introduce yourself? Sorry, I can't quite see you.
Deenan Pillay, Professor of Virology at UCL and a member of the Sir David's group. This is the answer is for consistency, as we just heard yesterday, which we welcome, that port quarantines will be instigated for a period of 14 days. And I think it's important we do have consistency around our infection control processes, given how difficult, of course, the backdrop is, how difficult it is with mixed messages, which we've seen over the last couple of days. So 14 days, we recognize, is the period of time that will really, really maximize the impact of the policy.
Thank you. Anyone else from Independent Sage need to respond on that? No, right. I'll take the next question then. Gareth Iacobucci from the British Medical Journal, please.
Hi there. My question really is, what does success look like for the group in terms of the next few months? Obviously, you're hoping that the government will respond to these recommendations. I just wondered if somebody could sort of set out what you would see, as a good outcome following this report.
So, David, did you want to respond first to that?
Well, just very quickly, we would say that we have had some successes in the last week. While we were meeting on Monday last week, the list of SAGE members was published by the government with some redactions. And then during the week, the minutes of earlier meetings of SAGE were published with, again, redactions. We saw this as a step forward, and we saw this as government responding to some of the things we were saying. So the first measure of success, of course, is going to be how government responds to our 18 recommendations, each of which has been thought through very carefully. And as we move forward, of course, we plan to hold further meetings.
Anthony, thank you. Anthony Costello wanted to speak as well.
Yeah, thank you. I think success ultimately is about suppressing the virus, not simply managing its spread through our country. This has been a concern from the beginning because the World Health Organization, and we've based our report very much on their principles, has been to say you must always find the virus, every case, test for them if you can, but if you can't, you can still identify, trace, isolate them, and make sure that your isolation policy is appropriate for whether somebody's sick or not, whether they're vulnerable or not, whether they can actually stay at home, support them, and then do social distancing. But you have to do all of that, and most important, do all of it at speed. And the countries that have done it at speed, like Korea, like many of the Asian states, like Germany, Denmark, Norway, Greece, have shown that they could suppress the virus within about 3 weeks and get the deaths right down. Many of them have death casualty figures in the low hundreds. So that's something that we have felt has been missing, accounts for the current state. And at the moment we have, according to Professor John Edmonds from SAGE, 20,000 cases per day. And that is not at a level that is sustainable. It's not just about the R number, and I'm sure Professor Friston could talk about that. It's about the existing prevalence. We have to get it right down and then have a integrated, sustainable, find, test, trace policy linked to GPs, linked to local public health, so that we can really get this epidemic right down. And that will preserve the economy, because our fear at the moment is if we release everything too soon without that in place, we will quickly be back to a new surge, and then the only choice being a national lockdown that will further damage the economy. So that's what success will look like.
Alison Pollock, did you want to comment?
Yes.
And then Zubaydah Haq as well.
One of the big issues has been the failure to protect older people and vulnerable groups. We're seeing more and more data on the effect on social care and nursing care residents, but also Black and ethnic minority groups and people. Can you hear me all right? I'm not sure if you can.
Yes.
So what this is our success will look like putting in not just local control measures, as Anthony has suggested, but making sure that we really are doing our best to shield and protect older people in nursing homes and residential care homes. So in a way, that means that the government now has to recognise the enormous fragmentation that has taken place both in health services and in social care services, coupled with a disinvestment that's been going on since at least 2008 before that. And by recognising that and reintegrating services so that the responses can happen. And that's why we've made some specific recommendations around increasing the staffing levels in nursing and residential care homes and making sure that care workers actually have proper terms and conditions of service, which also means making sure they have sickness benefits. Because what we do know is that care workers have been very vulnerable, and so have the residents, because the virus has been carried into the homes and around the homes and back into the community. So it's really important that we understand what's going on in local communities and put in the local measures and rebuild the local capacity, as Anthony has said, and that's set out in our recommendations.
I know 3 other members of the panel wish to speak to this issue, so bearing that in mind, if that's okay, I'll move on. Zubaydah Haq, and then Susan Michie, and then I'll bring in Kamlesh Kunti.
Thank you, Alison. I think I very much want to echo what Alison said, which is that success.
Louder.
Sorry, can you hear me? Can you hear me?
Yes,
now?
that's better. Thank you.
I think I very much want to echo what Alison said, which is that success isn't, and indeed what Anthony said, which is success isn't just about bringing down the average COVID-19 deaths. Success is about protecting and shielding every community in this country. You know, this pandemic starts with communities and it ends with communities. And that includes, of course, as Alison rightly pointed out, the vulnerable groups in our society. Now, it's really interesting, Samira, we've had statistics. This government has finally shared statistics which highlight that those living in deprived circumstances are twice as likely to die from COVID-19, that some BME groups are 2 to 4 times more likely to die from COVID-19. So it's important that the government brings out not just health measures, but also social and economic measures which protect and shield those vulnerable communities.
Thank you. Susan Michie.
Thank you. Susan Michie, Professor of Health Psychology.
My apologies, sorry.
At UCL. Just to add to what my colleagues have said, another measure of success is population-wide behaviour change, because behaviour is at the heart of the transmission of this virus, both directly from sneezing and coughing into people's faces, but also through touching surfaces and objects that other people touch. And the behaviours are quite simple, they're quite discreet. And if all the population adopted the behaviours that are recommended, the virus would stop dead in its tracks. And it's a long while since we've had government campaigns about cleaning your hands in the appropriate places and times, ensuring all coughs and sneezes are caught in a tissue that is disposed of immediately, not touching nose, mouth and eyes, which is where the virus gets into the body, and keeping 2 meters distance. Now, it's not enough just to tell people what to do. There has to be skills training, there has to be environmental support to ensure that these become maintained population-wide habits. And the 2 meter social distancing is absolutely dependent on the social and material environment around one. And this is where the Wednesday's new policy of people going back to work and inevitably having to go on public transport raises huge issues and challenges.
Thank you. Kamlesh Kunti, if you could introduce yourself as well. Thank you. And unmute. That's it.
Hi, Kamlesh Kunti. I'm a professor of primary care diabetes and vascular medicine at the University of Leicester, with an interest in Black minority ethnic health populations. I think we're seeing now really good data coming out, particularly from ONS that we had last week, the kind of people who are more disproportionately affected, such as the low socioeconomic groups, such as the main populations. And now we've got excellent quality data on occupations as well. And what we really need to do is act on all these data points and to ensure that culturally appropriate messaging is going out to these communities, and appropriate measures are being taken place, especially in terms of occupations and in terms of the housing. These are multi-generational housing that these people live in, to ensure that if there are people who are infected, to reduce the spread of the virus in whatever way necessary.
Thank you. If it's okay, I want to take the next question, which is Nina Massey from PA. Do go ahead. Right. Am I wrong, or is Susan Massey not there? Is it Nina Massey? Apologies if it's my error. Yes, Nina Massey. Right. I'm going to move on to the next questions. I can't hear you, Nina. Sorry. I'll come back to you if you're there. Ian Sample from The Guardian.
Hi, everyone. Thanks for doing this. The government announced the creation of a biosecurity centre in its plan to rebuild yesterday, and part of its responsibilities would be to monitor for future outbreaks. I'm just quite keen to get your sense of whether the kind of strategy and testing that biosecurity centre and even its establishment, whether that sort of resource seems to be up to the job that you foresee we will need in the future, for basically keeping a track of and clamping down on future outbreaks.
Who'd like to take this one first?
Deenan.
Deenan Pillay.
Thanks, Deenan Pillay, Virology, UCL. It's an example of yet another structure that is being proposed to deal with what are fundamentally public health emergencies. The UK has had a long a long and deep history of both the intellectual as well as the practical components of infection control, starting with the formation of the Public Health Laboratory Service at the time of the NHS. Given the way that this current COVID-19 pandemic has been dealt with, I think it's been clear, and this is not controversial at all, that capacity has been inadequate, needing a rapid initiation of a whole range of new structures, whether that's Nightingale hospitals, whether it's Lighthouse laboratories, whether it's a different sort of track and trace structure. And I think the ethos of our report is that we really need to, for the sustainability that will be required in this pandemic, let alone future pandemics, because in the absence of vaccine, as Sir David has said, we're in here for the long haul. Whatever our approach needs must be embedded within our existing structures. And we do have a number of structures, whether it's Public Health England or it's the NHS and the Office of Life Sciences and MHRA for regulatory and the Office of National Statistics and so forth. It does seem worrying that another structure has been set up to try and deliver what in fact we're arguing for as a sustainable long-term solution embedded within localities that can deliver protection.
Thank you. Alison Pollock. Oh, you're mute still, sorry.
I would agree with everything Deenan says, and here the history is really very important of what's happened to Porton Down and the laboratory service. 30 years ago, we had 50 public health laboratories. We're now down to 8 in Public Health England. And as Deenan said, capacity has been further shrunk due to a number of structural changes and enormous disinvestment that took place, nearly £500 million that was left out of Public Health England. So what we're arguing very strongly is the need to rebuild local capacity, local laboratories, which are really essential for surveillance, and also that regional and capacity as well. And it should be part of a properly integrated structure. Even the term biosecurity is really worrying. I think we should be thinking about surveillance for epidemics and disease control. And that should be embedded in the system, and that calls for reintegration and investment.
Thank you. I hope everyone could hear. It was breaking up a little there, but I think we got you. Thank you so much. Can I take the next question, if that's all right? Okay, Camilla Hodgson, Financial Times. Do go ahead. Right. I don't think I can hear you. Camilla, is that you? No, I don't think so. Message me if you are there, but I can't hear or see you. Next question, Richard Horton, Lancet.
Thank you very much. Some of the recommendations in the report for protecting vulnerable groups, such as the ones Alison's just been talking about, building up public health systems, laboratory capacity, integrating health and social care, will take some time, maybe years. And we don't actually have years. So what do you want the government to do in the next 3 months to protect vulnerable groups? Because the danger is that your recommendations are so long term that they'll simply become a manifesto for government inaction.
Thank you very much, Richard. Anthony Costello, did I see your...
Yeah.
I'll take that one on first, yes.
Thanks, Richard. I mean, you're right, there is a long-term component, but there's also a short-term component. I mean, if you get sick, everyone at this press conference goes to their GP, and their GPs know about you, they have all your documentation, they know about your family, and they should be an integral part. And indeed, if you talk to people in the front line, the public health local outbreak management teams, the health protection teams, and all the GPs, there's been a huge transformation of primary care over the past 2 months, bringing it more online, setting up hot hubs, doing all kinds of things in the community, and linking in with mutual aid groups, community groups who are providing support. So it's not that there isn't anything going on, it's just that it seems to be divorced from government planning. And what we're saying is we have to devolve. You know, I can't remember the exact number of local authorities. I think it's 408 in the United Kingdom. But, you know, if they're given clear guidance and you devolve power and give them the resources and tap into the 5,000 environmental health officers and the 750,000 volunteers that signed up 6 weeks ago, and many of whom have not heard anything since, I think we do have a capacity to move quite quickly. And that's what actually China and Korea and Taiwan, they got all their systems up within a week or two. A bit chaotic at first, but we've had plenty of time to do this, and we need to devolve that power so that we can get the short term to solve the problem of suppression, and then we can deal with the longer term.
Zubaida Haq.
Richard, I think if you have a look at our report, you'll see that actually we've made several recommendations around short-term measures that will protect and shield vulnerable groups. Now, I think one of the things that's not understood as well is that it's not just health measures that the government are making that are impacting and shielding vulnerable groups. It's also the social and economic measures. That's why Rishi Sunak came out with the economic measures that he did for employees and self-employed. But what we're arguing is that the economic and social measures have not been sufficient to protect vulnerable groups. There is a reason why people in deprived circumstances, why Black and ethnic minority people, why people in low-skilled occupations, which the ONS highlighted yesterday, there is a reason that all of those groups are much more at risk of COVID-19 deaths. They've been dying at much higher rates. And that's because for many of those people, while the rest of us have stayed at home, they haven't stayed at home. They've had to go to work. And for them, there isn't a choice between working in an unsafe environment and putting food on the table. That's not a genuine choice. When you've got a choice of working in an unsafe environment versus feeding your family or starvation, you will work in an unsafe environment. And that's where the government, in the short term, this is what we've said in the report, need to improve the social security net for people in lower paid occupations, as well as improving the housing benefits, the child benefits, and the universal credits, all of which will allow people to make genuine choices between going out to work in unsafe environments and staying at home and still being able to look after their families.
Kamlesh, Kunti, and then I'd like to take another couple of questions in while I can. Thank you.
Hi, Richard. As everyone said, there are short-term measures that are being put in place, but as you know, there is enough research evidence that's come out from previous natural disasters such as tsunamis and earthquakes that we not only have the short-term consequences but the medium and long-term consequences, and I think we need to prepare for those now, having both health and social care integrated, because we've had disruptions in terms of the consultations that we're doing in primary care. We've reduced the number of consultations, hardly seeing anyone face-to-face. Most of it's been done remotely. And the people who will suffer the most are people with chronic diseases, as you know, because they're the ones who are not getting the care that's required. And I think we need to start planning for that now, so that in the short term and the medium and the long term, we get them back on track and get their risk factors managed. Remember also the psychological support this population is going to need. We've already seen 50 to 60% increased risk in terms of psychological stress and depression levels. That also puts a huge burden on these patients. We know their lifestyle are changed, their adherence to medications are changed. All of this needs to start now, and then we need to continue in the medium and the long term.
Thank you. Can I take a question from Pallab Ghosh, BBC, please?
Hi, thank you, Samira. I'd just like to ask the panel their views on the ways in which we're going to monitor the R-value. My understanding at the moment is that the way of doing that, the best way, is to look at hospital admissions. But do we have in place what's necessary to monitor if easing of the measures are getting out of control or working? And just as a separate question, I'd just like to ask you, you're a group of experts in your field, a dozen of you or so, that have been working on this for a week or so. what can you offer that the 200 or so people on the official stage working for 3.5 months haven't been able to offer?
Carl Friston first.
That's an excellent question. I think the independent sage, from a scientific perspective, our role is to offer alternative hypotheses. So very much like the scientific process, putting other approaches, other expertise, perspectives on the table. And I think the issue of R highlights a potential success of this independent sage in bringing to attention or alerting the theoreticians and advisors to other ways of looking at the problem. So let's just look at the R value. And perhaps if I use a metaphor, just to give you an alternative perspective on it. The metaphor is that you're in a room and it's getting cold and you want to decide whether to put the fire on. You know, for example, relaxing social distancing. So what metrics, what things would you look at? What states of affairs would you use to underwrite your decision as to whether to turn the heating on? Now, the R value, as Graham Medley was saying last night on Newsnight, is a measure of the rate of increase or decrease in the prevalence of infection. In our analogy, whether it's getting warmer or colder. It is not in itself a measure of the actual burden, the actual prevalence of the infection, i.e. the temperature of the room. So predicating your decision-making on the R value is a little bit like being very, very cold and not putting the heating on because the temperature is still going down. So that perspective brings into question the sort of formalism and the understanding and the modeling of what's going to happen if I do that, which in turn speaks to what would you actually want to base your decisions on, which is clearly the viral load in the population. So that in turn speaks to this notion of real-time forward modeling, assimilating the data day by day as it comes in. Whether it's good data or bad data, we can write down the goodness and the badness into the models. So now we're moving away from a conventional epidemiological modeling scenario into a data assimilation, dynamic causal modeling approach, which is well developed in other areas outside epidemiology. So we were asked before, what would success look like from the point of view of the independent sage? Success would be to have the government and its theoreticians consider an alternative way of modeling, quantifying, understanding, inferring what's going on today and next week, as opposed to looking at what has happened last week using metrics like the reproduction ratio. There are mechanisms to do that. The RAMP initiative is probably the most efficacious mechanism. That's sort of coming online now in terms of providing a forum for academics and modelers to be more eclectic in their expertise and triage that advice and then feed that through to the SBIM and SAGE itself. That hasn't really happened yet. There are lots of voices out there that haven't yet been heard, providing a different kind of expertise, which actually might be more apt for the problem at hand.
Right, could I just see to David first and then Zubaida?
Pala, I'm just addressing the second half of your question, or your second question, in slightly different terms to the way Carl has responded. We are a very dynamic little group, and although we've only been working for a week as a group, each one of the people in the group has been working for very many years. So there's many years of experience. We also come to this from very different ranges of experience. So what we have, I think, in a group of 12 people, and you know, if the group gets too many, as we all know, it becomes very difficult to keep it all moving in the same direction. So keeping it down to 12, and by the way, when I was Chief Scientific Advisor, that was a key, I think, to the way I moved forward, is quite a good idea, as long as you're covering the spectrum of capability and expertise in the country. And I think you will see that we are doing that. But more than that, and very importantly, is transparency. We are demonstrating what it looks like to do this in the public domain by having our meeting last week available to the public to watch, by having our publication open not only to the government, but also to the public. By immediately we've sent it to the government, having this press briefing. All of this is to demonstrate what an independent science advisory group should look like. In other words, it took a bit of pressure from us before we saw any of the minutes of SAGE. We were told that the membership of SAGE was secret. Why on earth would you want to be secret? Now, I know that some of my colleagues sitting around you now have received abusive tweets, and of course, so do I. But, you know, we have to develop thick skins to that. What we are focused on is delivering what is in the best national interest at this point in time, and doing it openly so people can judge whether or not the government is following the best advice.
Thank you. Zubaida.
Pala, that was an excellent question. If I may say this, having worked in government for quite a long time through several government departments, government can receive a lot of advice from many sources, stakeholders, and so on. But it doesn't mean that government are operating in an ideological vacuum, and I think that's quite important to understand. And as David and Carl and others have said, which is that what we wanted to do was to make sure that our advice, our expert advice, which was transparent, was clear, and was looking at all of the evidence, the social, the economic, and the health evidence, and looking at the interrelationship with that. We also, and in fact, we've made a recommendation about this as well, is that we also wanted to ensure that even communities, as well as the third sector organizations, civil society organizations, also get a voice and say in this pandemic. So that's all we wanted to do. And I don't think it's about numbers, it's about the filter in that advice that's important.
Right, can I take the question from Camilla Hodgson at the Financial Times now? Others, I've got it in front of me.
Hello.
There you are.
Sorry, can you hear me?
Absolutely, go for it.
Great, thanks so much. I want to ask about contact tracing and why initially PHE only had a couple of hundred contact tracers, and then looking ahead, whether the 18,000 that they are recruiting is going to be enough. I'm not really sure how to judge whether that's a big or a small number, other than that it's an enormous change.
Alison Pollock. Yes.
So it was a puzzle as to why contact tracing stopped on the 12th of March. And we were given two reasons: that it wasn't effective and there weren't sufficient resources. They seemed to be linked together. So by the time it stopped on the 12th of March, only 3,000 contacts had actually been contacted. And of those, there were 120 confirmed positive cases. So considering the population of the UK, I think that shows you how things were. And what we do know is part of the reason for the contact tracing not continuing was that Public Health England only was operating out of 8 regional hubs serving 343 local authorities. So it just didn't have the capacity. But contact tracing is the bread and butter of public health. And it needs to be done locally and in local communities, which is what we're arguing. You have to understand your local community and the extent to which they're able to comply with isolation and quarantine and their living circumstances. That's really important. So it was a great disappointment that the government has not rebuilt capacity over the last 2 months in local authorities, which are the best place. There are no health bodies, area health bodies anymore. Public health is sitting in local authorities, but unfortunately, communicable disease control is in Public Health England. So you've got extraordinary fragmentation. But what the government could have done, and we hope it will still do, is rebuild contact tracing locally through teams. Now, it's not difficult to do contact tracing, but you will need tens of thousands of people But after all, there are 750,000 volunteers, and that could be done locally with local authorities rebuilding the contact tracing teams with environmental health officers, with GPs, having community monitoring in place so that people receive packs of thermometers and also oxygen saturation meters that can be recycled, and they receive the support to see whether they can get isolation. Because, as you know, this is not one national epidemic. It's really, to use the fire analogy, it's thousands of outbreaks that are going on. And when you want to put out a fire in Blackpool or Cumbria or the Isle of Wight, you don't actually call the fire engine from Westminster and London. You have to do that locally. And that way you engage, you understand your local communities, and you make that work. Of course, contact tracing is a package of measures, and you can add to that testing and apps. But it's very bewildering, the government's decision to outsource contact tracing to Circle and to have a centralised system. This doesn't make sense. The centralised app, the centralised systems, and the centralisation of laboratory results as well, this isn't making sense for contact.
Thank you. Christina Pargle and then Anthony Costello.
I just wanted to add to that, that tracing on its own is useless unless you're going to isolate people who've been in contact with infected people. And although the government talks about it in its report yesterday, it doesn't actually provide support for how you effectively self-isolate, particularly for the vulnerable populations we've been talking about, where maybe you can't afford to self-isolate for 14 days. Maybe you're living in a situation where you have shared bathrooms or there's a crowded area. How is the government going to support people to isolate effectively so that they're not infecting their households as well?
Anthony Costello.
Very quickly, a paper was published at the end of last week modelling various approaches to test, trace and isolate by several of the people on the official stage, very good modelers like Adam Kucharski, and I think John Edmonds was involved, and a whole team. And basically it showed that mass testing is not going to get your R0 down. The best way to get your R0 down was with local testing and manual contact tracing, especially of close contacts, family contacts, rather than going for these big apps that are trying to measure whether you've been 1.8 meters from someone on a bus somewhere. I mean, you know, it's got to be joined up, it's got to be local, it's got to be integrated, and the data's got to get back to both the patient and the GP if you're doing testing and tracing. And that's not going to happen with call centers in Berkshire and, you know, Deloitte somewhere else. It's, you know, it's got to be joined up.
Carl Friston.
Yeah, just in response to the question about, you know, are the facilities and the numbers going to be sufficient to make a difference in terms of deferring any potential second wave? The numbers actually look quite optimistic for a particular reason, and that reason is that we've actually inherited, in principle, a degree of herd immunity from the first wave that puts us in a much more comfortable position now than we were before the first wave, which means that we don't need to have 100% tracking and efficacy of that tracking in order to make a difference, according to the epidemiological models, these sort of forward models. So I think that's an important endorsement of current enthusiasm to get back to tracking and tracing, and it's certainly endorsed quantitatively by the modeling. And interestingly, under idealized assumptions, the numbers of tests per day that you would need to do to deploy in an FTTI fashion is actually well below the current capacity that the government built up, you know, in the recent weeks. So I think that's quite encouraging. Another sort of obvious point, which I don't see emphasized in sort of media discussions of this, that the only kind of testing that matters in terms of attenuating the virus and its spread is catching people who are infected but not symptomatic. So going back in time and identifying them before they can spread the virus. So you know, that's why it's a specific application of testing, tracing and tracking and deploying resources there at a local level, again, where it matters, that's going to make a difference. It won't make any difference just increasing the number of tests or testing people who are symptomatic so they can get back to work. That will clearly ease pressure on the economy and the care provision, but it's not going to actually suppress or attenuate or defer
the pandemic in and of itself.
Thank you so much. I'm not actually sure how much time we have left, but let's just keep going if we're not falling off air. Can I ask if there's someone from the Daily Mail who wanted to ask a question? We have you on the list. Otherwise, you can message me on the chat. And also, oh yes, go ahead. Who's that?
Okay, it's Colin Fernandez from the Daily Mail.
Hello, Colin. Go ahead.
Hi. The membership of Independent Sage appears to be largely people with left-wing political affiliations. Was there any attempt to seek a wider balance of political views in the makeup of the panel? And does this affect at least the perception of Independent Sage as critics of the government? That's the first question.
Well, can we stick with that one, okay. Colin, to be fair? Thank you very much. I think, Sir David, you wanted to take that one first.
I very much hope that anyone watching this briefing, anyone reading our report with the kind of detail that it needs to take to read it, will understand that what we've put together is quite simply a range of the best experts available to us who could work on this problem. There was never any point at which we looked at political affiliations amongst the members of this group. And it does seem to me utterly absurd to suggest that this is in any way politically right or left. We don't recognize that, because what we're doing is attempting to demonstrate to everyone in the media what a science group looks like without any political interference with its workings. And that really, I think, has been extraordinarily successful. What you've heard, I'm sure you've been listening very carefully to all of the answers, is the kind of expertise that is sitting in front of you here. So please remember, when you're writing headlines for your newspaper, remember to focus on the science. If you can find any fault with the science, please take us up on it. But to suggest that this is a politically biased group is to entirely miss the point.
Thank you. And Matt Roper from the Daily Mirror. If you're there. Right, I think that's it. The only other thing I wanted to ask, and it was Susan Mickey, something you said quite early on, you seem to be expressing concern about the stay alert element of the message. I just wondered if the panel had any other thoughts, because that has been one of the big issues over the last couple of days, concern about the messaging.
Well, I think the concern about the messaging is twofold. One is the issue about consistency, ensuring that the message is very consistent, and the other is that it's clear, and especially clear in terms of what people should be doing. And I think the concern with the actual slogan of stay alert is it's not very obvious what alert means, what people should be alert to, what they should do if, when being alert, they identify something that isn't defined. And the next bit of the slogan is control the virus. Again, it's a bit content free in terms of how we're meant to be controlling the virus. So I think incredibly important, and the public have been asking for this over the last few weeks, to have really clear, behaviourally specific advice about who should be doing what and where. And I think this becomes ever more important as the easing of the restrictions is going to be a lot more complicated than the imposing of them to begin with. And it means that different sections of the population are going to be expected to do different things in different situations. And a lot of people are going to be very anxious about the current situation in terms of going into unsafe situations, bringing the virus back into the household where there may be vulnerable people. And in these circumstances, more than ever, we need really clear messaging, but also objectively verified safety on the ground, so that the lowest paid people, the most vulnerable people, aren't the ones who are going to be expected to go back into unsafe working conditions and travelling on unsafe transport to get there. They lose, society loses, the economy loses.
Thank you. I've got two questions I want to just fit in before we finish. One is from Adam Vaughan at New Scientist. Go ahead.
Thanks, Samira. Hi, I understand the government's reproduction number estimate is based largely on the rate of hospital admissions. I just wondered, can you, this is probably one for Carl, I suspect, can you unpack what is wrong with how the government is estimating the R, including this idea that the data is a month out of date? And can you spell out in a bit more detail what you think it should be replaced with?
Thank you. Carl Friston, you happy to take that?
Sure. Yeah, I think saying it's a month out of date is probably overstating the problem. So my understanding is that the current estimators feeding into government advice are based on something called Bayesian regression from Imperial College, which is state-of-the-art curve fitting, basically. And that's probably the best that is available using conventional epidemiological modeling. And I use the word curve fitting deliberately because what that immediately implies is you're fitting parameters to a data curve that has already occurred. So that's what I think Sir Dave was intimating in terms of it is retrospective or backward looking. It is a characterization of something that has happened. I think that if you look at the actual data that the government have been using, it's really reflecting what's been happening over the past, say, 10 days or so. But it is the past. What you'd really like, and what is potentially available if one adopted an online real-time data assimilation dynamic causal modeling approach, is the best estimate today. And that's what we're hoping to explore as an alternative way of quantifying the state of affairs at the moment by building all our knowledge about the mechanisms and the process of the virus, including societal responses like social distancing, including interventions of non-pharmacological and pharmacological sort into the model to get a very precise estimate with confidence intervals about the levels of infection today. From that, you can then derive the rate of change of that quantity that itself then constitutes the R number. But to get those models in place, they have to be evaluated in relation to conventional epidemiological models. So we now face a meta-scientific problem of getting experts whose expertise is in epidemiology to talk to experts in control theory, Bayesian modeling, the modeling of dynamical systems, to see if there's any utility in moving towards a sort of 21st century approach to understanding, most generally sort of non-equilibrium, steady states and dynamics that are the mathematical basis of what we're seeing going on around us.
Thank you. We've got about 5 minutes left. I've got a question from Alexandra Thompson at Yahoo. Alexandra.
Hi there, can you hear me?
Yes, we can, thank you.
Hi, I wanted to talk about the stay alert message. England is the only part of the UK that has changed from this stay at home. In your opinion, was that listed too early in the trajectory of this outbreak? Should we all be staying at home rather than staying alert?
Thank you. Who's going to respond to that? We have been talking in a sense around this very question, haven't we? Yes, Zubaida Haq.
The staying alert doesn't protect vulnerable communities, vulnerable groups who have been forced, if you like, to go out to work. Because as I mentioned before, for many people, there hasn't been a choice about going out to work in unsafe work versus having to feed their families at home. So in that sense, it's the staying alert, it's not an appropriate advice for groups that are very vulnerable. And the government is very aware of which groups are very vulnerable. It's not just the elderly. We know it's people in lower socioeconomic groups, lower paid jobs. We know it's particular Black and ethnic minority groups. And in that sense, I think it has been a message that is likely to put more people at risk. And we're very concerned about that. We're also concerned, of course, that there is a disparity between what the rest of the nations are doing in the UK and what England are doing as well.
You're muted.
Yes, such a pro, aren't I? We're in the last 4 minutes. I think Deenan Pillay, you wanted to come in on this issue. Do go ahead, Deenan.
Just briefly on this issue, and of course the policy of stay alert came, at the end of our deliberations, so we haven't really addressed that specifically in our report. But it does strike me as very unfortunate timing that literally within 24 hours, an ONS report states that there is double the death risk in those individuals, precisely those individuals who cannot work at home and have to go out to work, at the same time as government advice says those who can go out to work should go out to work. And I would support that concern that other members of the panel have about the impact and meaning of the move from stay at home to stay alert.
Sorry,
yes, Zubaida.
I'm really sorry. I didn't realize, I think because of my internet connection here, but that's exactly what I was going to say, which is it's not a genuine, the stay alert is not a genuine choice for vulnerable communities. As Deenan says, for many people, there isn't that choice between staying at home and going out to work. But we know that the stay at home message has been very effective. We know that's what's been protecting communities, vulnerable communities, even communities living in overcrowded, multi-generational homes. Arguably for them to stay at home is more protecting, is that they've been more protected that way than going out to work. So to some extent, this is a reckless message, and it puts the onus of responsibility on individuals who don't necessarily have all the information to protect themselves in this pandemic.
Thank you very much. Anthony Costello.
Just to say that the most important thing, look, the government faces a huge problem between a health crisis and an economic crisis. And of course, the two are linked. And the most effective form of social distancing is to find, test, trace, and isolate the people who've really got the infection and their contacts. That's what's going to bring down your R value and enable us to open the economy more quickly, stop the bankruptcies, stop the unemployment, and eventually stop the furlough and the huge debts that are being incurred. So that's why we're pushing that very hard. The question of stay at home is, at the moment, is also about whether or not we've gone far enough with the lockdown. But the longer you go with a lockdown, the bigger the risks to the economy and all the other social effects. And so I'm sure there would be mixed opinions on the panel about when that should actually happen. But we've got to get the number of cases down. We've got to suppress this virus. Then we're going to be able to open our economy very effectively. And to do that, we've got to get our integrated local control mechanisms, infection control mechanisms to suppress the virus. Find it, test, trace, isolate, and then add in whatever social distancing we can do and all the behavioral aspects. But that's what we've got to do if we're going to really get going again and restore our economy and get people back to work.
Thank you so much. I think we're pretty much out of time, unless, Sir David, you had any final thoughts. Just you're mute still, sorry.
I think the only comment I want to make at this point is that the group as a whole has been working exceptionally well, and building on that, we are planning to have a further meeting, and we may even go beyond a further meeting. So all I wanted to say was, please watch this space. We will be continuing the piece of work that we began a week ago. I want to also, if I may, just again thank my colleagues, an exceptional team of people who have all worked extremely hard on this over the last week. And at the same time, every one of them has got a very challenging day job. So it's been a wonderful team to be a chairperson of.
Thank you so much. Thank you to all Independent Sage for holding this news conference, and to everyone who's attended to ask their questions. Thank you again. Goodbye.
Thank you.